Hello, hola, and namaste. I'm Darshana, and I'm going to be your host in this virtual space, Pelvic Gyan, the one thing. I'm a women's health physiotherapist, and I'm hoping to have conversations with a variety of medical and non-medical providers about anything and everything related to pelvic health, from pee, poo, pregnancy, postpartum, sex, pain, and more. This is a passion project to increase awareness and to get the dialogue started. But this is not medical diagnosis or medical treatment. If you have specific health conditions, please reach out to your providers and do not take your medical advice from the internet. Thank you for spending time with me. If you have any questions, comments, feedback, I would love to hear from you. Let's get started. Hello, everybody. This is Darshana, and thank you for listening in. Today, we have with us Dr. Krystyna Holland, who is an expert clinician and the owner of the practice Inclusive Care Physical Therapy, which specializes in helping people with pelvic pain, improving intimacy, and stopping leakage. Krystyna's journey started as a patient, so she knows firsthand the power of pelvic floor physical therapy in addressing problems and improving life and getting people doing things that they love doing the most. So I'm really glad that she's taken the time to speak with us today, and I'm really excited to get started. Hi, Krystyna.
Hi, Darshana. Thanks so much for having me.
How are you doing?
I'm doing well. Yeah, it's rainy here in Denver, Colorado today.
And it's sunny in Seattle. Can you believe it? It's very
no,
sunny.
I really can't.
Me neither. It won't last. Don't get used to it, they say. All right. So I wanted to start with like a question that I feel like every pelvic PT gets asked by 99% of their patients. You know, like, how'd you become a pelvic PT? Like, why do you do what you do? Like, how'd you get here? So can you share a little bit of your journey with us, please?
Sure. Yeah. So I had a pelvic surgery when I was in my third year of physical therapy school. And I became a pelvic floor patient at that time. So I had my own issues with painful intercourse, my own issues with not being able to empty completely, my own issues with urinary leakage. And so kind of through that process, I saw what it was like to manage the medical system and be managed by the medical system, especially with things that felt really intimate. And so I was already in PT school at the time, but it was really, really motivating and affirming that that was what I should do.
Oh, that's excellent. Not a lot of people, get that experience firsthand. So, what are some of the takeaway points just, as a clinician on the other end to be mindful of patients who are experiencing this? Like, what are some of the things that you felt were really powerful or good about the healthcare system that we need to kind of make sure we keep reinforcing?
Yeah, that's a good question. I had a really, really good pelvic floor physical therapist who was very gentle. I didn't ever feel rushed. She was very thorough in her explanations. She didn't mind if I asked a lot of questions. She really reinforced that everyone's body is different, and that even if I didn't respond exactly how maybe I thought I would, that it wasn't because my body was broken or not doing anything wrong, or because I was being purposely difficult. And so all of those things were really, really positive.
Yeah, that's such a powerful message, because I feel like we all get asked that question of patients often feel like something's broken. And when you feel your body's broken, it kind of not only affects your body, but your mind at a very deep level, especially when these problems are happening in younger women. It can shape their life and their experiences coming on. So I'm glad that you found that one clinician. Was there anything that kind of strikes out as a very, hard or negative experience that we can kind of learn from and advocate better for our patients in that area?
I think just reminding patients that they have a voice, and that what they believe is important is in fact important, and that, as an expert or as a clinician, you have an expert in the medicine, but you don't have an expert on someone else's lived experience. And so you need both of those things to be able to come up with a treatment plan that's going to actually get your patient the result that they're looking for. And so just remembering that as a clinician, that if something isn't working, it's okay to change paths. It's okay. If it's not a good fit with a patient, it's okay to refer out. And just reminding yourself that it's about, even though your job might be a little bit harder, it's the patient's life you're dealing with. And so just remembering that and kind of prioritizing those things, I think, are things that we can always be reminded of.
Yeah, and thank you for saying that, because I feel like a lot of times patients don't realize that we're a team trying to
get them to where they need to get to. And sometimes they feel like by rectifying somebody, they're going to get in trouble almost, because you don't want to like argue with your medical team. But I think what I heard is patient's goals are what you're chasing and not what your goal might be for the patient. So I think that might be nice for patients to hear, that it's okay to speak up about what their goals are.
And it's important. It's so important. Like as a provider, when I ask people, what do you want to work on, or what's important to you, or what is really like bothering you in your life, I'm not just asking because I'm curious. I'm asking because this is how we get you to where you want to go. So I need to know kind of what the destination is.
Yeah, excellent. So in your current practice, what are sort of like some of the common things that you treat or see?
Yeah, so I treat a lot of people who are having painful intercourse, dyspareunia. I treat a lot of persistent pelvic pain, people who've had pelvic pain for a long time, pregnant and postpartum folks who are either just worried or want some more confidence or want to go into their delivery knowing what all the options are, and then people who are leaking or have pelvic organ prolapse.
And have you noticed any particular diagnoses that come with a lot more barriers of, not wanting to seek care or having difficulty? I feel like people sometimes get transferred to so many providers before they actually land in a pelvic PT's office. Are there any particular diagnoses that kind of feel like, okay, those diagnoses take a while before they actually end up in my office?
Painful sex, always. Like I actually just did a poll on Instagram, and I had over 50 respondents. And of that, there were so few people who, so many people who had had painful intercourse for an extended period of time, and so few of them that even talked about it with their providers, and then even fewer that were offered an intervention when they brought it up with the provider. So that is always the thing that I think it takes the most time to get in to see a pelvic floor physical therapist, because people don't know that that's even an option.
Yeah.
And people are really embarrassed to talk about it.
Yes, I mean, it's a very private, conversation. And I read an article that was talking about why people don't report dyspareunia. And, I often thought it's such a private and intimate topic. People feel awkward to talk about it and don't bring it up with their providers. And that article looked at like, if providers were to ask, like how many patients answered that if my doctor had asked, do you have pain with sex? They would have said yes. They wanted to say yes. They wanted the doctor to ask. But I feel like as a medical community, sometimes we don't treat sex as a function. So we ask about other things, but not that, especially for women around menopause. A lot of things are changing. They get asked about vaginal dryness, but nobody asks them, do you have pain with sex? So
right, I don't understand the disconnect either, because it's like we regularly treat people postpartumly or during pregnancy, and then we ask these questions about vaginal dryness, but we're unwilling to. It just feels like there's such a weird disconnect that all of a sudden we just can't bring ourselves to ask about an activity of daily living. Daily might be an overstatement for some people, but
yeah,
like a regular activity.
A functional activity at its best, So while we're on that, because I feel like a lot of people don't know what's normal, because sometimes it just gets, oh, you had a baby, so sex hurts, so that's normal. Because all my girlfriends told me that's how it's supposed to be, but not for 8 months. Maybe for the first 8 times, but not for 8 months, So can we just kind of cover like what's normal when it comes to bladder, bowel, and sex? Like what's considered normal?
Sure. So, such a good question. So for sex, I think the first thing that's worth noting is that it is totally normal to not have an orgasm from penetration alone. It is not. It is
common myth.
Yeah, seriously. It's like we have this big narrative that our sexuality is broken if we don't orgasm from penetration alone, and that's just not how it works. So that's good to know. It's not normal that if you're having painful sex time after time, that doesn't change with like positional changes. Sometimes even if it does change with positional changes, that you are having sex that like it hurts, not only like that's a little uncomfortable or it hurts like if you hit me in this one particular spot, but if your whole body is tensing and like trying to protect you and feeling like maybe you're trying to push your partner out with the muscles in your pelvis, that's not normal. So all of those things can be worked on. And when we talk about normal, right, I like to talk about, everyone, there is some amount of variability between people, and there are lots of things that are not normal per our anatomy books, per our education. And also, if those things don't bother you, that's okay. So if it really doesn't bother you that you're having painful sex and like, you're like, honestly, I'm by myself. I can have an orgasm by myself. I feel very positively about that. Or I can't participate in penetrative intercourse without pain, but my partner doesn't have anything that I particularly want to be penetrated with. Great. That's amazing. We don't have to work on it. But that being said, if it does bother you, there are options. So that's the whole thing.
Mm-hmm.
Um,
And
yeah,
when
go
it
ahead.
comes to sort of like bladder and bowel, what are some of the like normals that people need to know?
Sure. So if you feel like you're spending a large percentage of your day in the bathroom, or worried that you need to be in the bathroom, or worried that you're going to leak, all of those things can be worked on. Or feeling like you just can't poop, like spending a lot of time really constipated. Those are also things that really you could benefit from working on.
Yeah, because I feel like a lot of times, just like some of the other things we talked about, constipation is one thing where people don't realize, like PT can treat that. I mean, constipation is multi-layers, like there are different causes, but there are certain aspects of it definitely pelvic PT can benefit. And not a lot of people know that, because I feel like constipation is one of those things that has existed for so long, even they feel like that's the common and normal gets so mixed that we don't know when to seek care. So to that effect, are there like any ways, sort of like a self-screen that people can do or be mindful of, like, hey, if this is happening, maybe I need to talk to somebody about it?
Sure. So with constipation specifically, or
Just pelvic health in general, but we can start with constipation.
so if you are, you don't have to be able to poop every day, but when you do poop, you should be able to feel like you're completely empty, feel relief from that, feel like it comes out pretty easily. Your stool should be the consistency of about a ripe banana, and that you're not sitting on the toilet like straining and having to push, and that things are painful for a long time. In terms of urination, kind of similar in that you should be able to get everything out, feel relief, not feel like immediately after you urinate, you have to urinate again. Feeling like you're able to hold it when you need to hold it, and that you're able to go when you need to go. And then with sex, making, like, checking in with yourself, is anything painful or uncomfortable? Are you able to achieve an orgasm, if that's important to you? And are you doing that like tensing that makes everything that when you're having intercourse, are you doing the amount of tensing that is kind of like pushing things outside of your body?
So thank you for that, because it kind of helps people understand normal. And we also sort of talked about, if you have problems with any of these, pelvic PT can help. But are there certain areas where I don't have a problem? I don't have pain. I don't have pain with sex, or I don't have pain with pooping. But are there certain benchmarks for which, hey, that can get better? So for example, when I treat patients with primary complaints of anorgasmia, like, it's not painful, I'm fine. And
Mm-hmm.
as you said, if that's not your goal, cool, you don't need to see anybody for it. But are there certain other things where you can benefit from pelvic PT in terms of just improving function, not necessarily correcting a dysfunction or addressing pain?
Yeah, absolutely. So I think not being able to have an orgasm is a great one, a great example, not a great thing, for clarity's sake. Also, queefing is another. So vaginal flatulence is something that can absolutely be improved with pelvic floor physical therapy, but that isn't painful, right? And we don't
Mm-hmm.
necessarily always think about care during
If you skip
pregnancy and
yoga, it's not
postpartum. So
painful.
whether, yeah, right, exactly. But if you want to be able to do those inversions, that can be pelvic floor physical therapy can help with that.
It's so
And then,
interesting, because I just recently had a conversation with a patient last week about, like, so what have you done? And she said, I started doing yoga and I can do XYZ now. So I'm thinking, oh, is the pain better? Is that why you can do it? I said, no, because now everything is virtual. So I don't care what sounds I make when I do this. And so now we're talking about, oh, you never reported that you're in pelvic PT. So even people in pelvic PT don't report that, because again, we don't realize that can be rectified or that can improve, right? So thank you for bringing that up. Just a funny
yeah,
story.
to be fair, I have not yet asked. Maybe I should add it to my intake. Do you regularly experience queefing? I don't know.
Yeah, because some people just don't tell you that, right?
I'm also imagining how many people are going to ask me what queefing is.
Yes, actually, it might be less than you think, because I feel like the slang words are more popular than the medical terms, actually,
Mm-hmm.
right? So we've talked so much about, like, if this is happening, go see a pelvic PT. So what's a pelvic PT? Like, how is it different than physical therapy? Because, people have probably had physical therapy for a knee problem or a shoulder problem. So what's so special about a pelvic PT?
Yeah, I think that pelvic PT just looks at the body in a little bit of a different way. So your pelvis is like the center of your body. There are orifices, there are holes that go into the middle of your body. It is a place that we often will hold stress and trauma, potential histories of trauma. And so just knowing that, I think already changes the way that pelvic PTs work and how they look at movement and function. The other thing is that pelvic PTs, some of them are able to do work to tell you whether or not your pelvic floor muscles, which are the muscles that run around your vagina, urethra, and rectum, or penis and rectum, whether or not they're working. And that can involve an internal assessment, which is, people don't often know that. They're like, I'm sorry, you touch what? So those are always, internal assessments are not for everybody. They're not for every patient. They're not for every dysfunction. They're not for everybody, but they can be super helpful and very clarifying for a lot of people. So that's a good thing to know about.
And how is that internal exam different than, like, when people have a gynecological internal exam? And, I just wanted to kind of go over what are the things that we don't look at, because sometimes common conception could be, my pelvic PT just did a pelvic exam, so I guess I can skip my annual check. So I just wanted to clarify, like, what is the differences that we're looking at?
Yeah, that's such a good question. I don't ever so I don't use a speculum, right? So I don't look inside. So if there's something going on at your cervix that needs to be checked out, I'm going to be hard pressed to tell you because I can't see it. So that would be one thing. You definitely need to continue to get your annual exam, get your pap smear, those sorts of things. What I'm looking for is, what are the muscles of your pelvis doing? Are they working in a coordinated way? Are they really tight? Are they uncomfortable? Are they strong? Do you have good endurance? Do they work when they're supposed to, how they're supposed to, with the other parts that they're supposed to?
So the positive I heard is no speculum, in case somebody missed on that. One more time, no speculum.
And no stirrup either. So there's no awkward butt.
Yes, because I don't think I've met anybody who has not complained about speculums, because we're looking at muscles. They're a totally different level, and we don't necessarily, speculums have their own benefit, but just kind of different. So if that is a barrier for me, because sometimes I feel like patients know they have a need and they would benefit from pelvic PT, but there's just this, like, I just don't even want to enter a conversation about, can I do a vaginal exam, for a variety of reasons. It could be trauma, it could be sexual abuse, it could be just, I've never had sex and I don't want a vaginal exam, or just culturally, or whatever you have you. So what can you say to those patients that kind of ensures them that, okay, you can at least go do something external that might benefit, and is there such an option?
Yeah, absolutely. Honestly, I think I've seen this a lot with the COVID stuff. Like I've had a couple people that were like, oh, I think I want to schedule with you, but just wouldn't commit. And then as soon as I said, okay, inpatient visits are out of the question, I'm only doing virtual visits, those same people were like, okay, I'm ready now, right? Now that there is no option, there's no opportunity, I am not going to feel remotely like you could touch me. Now I'm okay, and I want to have an appointment. So with that being said, having an internal exam or even an external exam in vulnerable areas is always up for discussion. It is always patient choice. It is never the only option. And know that virtual is actually, you can get a lot of really good information, and I've had people have really great outcomes, and I never touch them.
That's excellent, because I feel like sometimes people don't say that's what they're afraid of, like in your case where virtual care, oh, you can't do an internal, so I'll say yes for PT, right? Mm-hmm. And it can be empowering when they assess their own self. So are there any tips for, like, patients or providers even who are listening, who are curious about, I wonder if I have that, I just want to, like, self-check to see if I can, or for whatever reason in their life they're not ready to seek out professional care just yet? Are there any sort of, like, DIY things that they can do to check function or fix certain things? Some simple tips.
I love the idea of a DIY vaginal exam. I'm so here for that. So you can use a mirror and take a look. And so when you do a Kegel, which would be a pelvic floor muscle contraction, what you should see is that the opening of your vagina comes up towards your head. It shouldn't come down towards the mirror. It should go away from the mirror. you should also see that if you were to bear down, like you were going to have a bowel movement or try and pass gas, that the opening to your vagina or your rectum actually goes down towards the mirror, right? When you take a big deep breath into your lower abdomen, one thing that should happen is that your lower abdomen should actually rise and not come in. Sometimes people think when I take a deep breath, my stomach comes in. We actually want it to come out. And when you do that, if you're looking at your pelvic floor should also come down just a little bit. It's very subtle, but it should move. So those are all things that you can check on. And you can just check with your hand and see if anything is tender or uncomfortable. And that can also be really helpful.
Thank you. And the next question I have is more for clinicians, because I know you have a lot of experience treating patients with trauma background, or, you know, kind of being more comfortable with a gender spectrum of language and mannerism. So, you know, I'm a pelvic PT who is still learning in my ways of being more gender inclusive when it comes to my language and my mannerisms. So what are some of the resources or tips that you have for clinicians that will help us prepare to kind of just be more inclusive?
Yeah, so I actually talk about this a lot on all things that I talk on. So I'm happy to send people podcasts recommendations, and also I talk about it on my Instagram. And also there is one course in treating folks who are transgender that is put out by the section or the Academy of Pelvic Health. So I would highly recommend that. And I think the biggest thing is just recognizing the assumptions you unintentionally make about people. And it's not bad to do that. We've grown up doing that, right? But what you're doing in gender inclusivity, for example, you see someone come in your door and you automatically decide, okay, I'm going to call them Mr. or Mrs. or Miss, maybe for progressive Ms. And what you've just done unintentionally is you've gone in, you've said to yourself, okay, I think that this person has these genitals, which means that they're this gender, so I'm going to refer to them in this way. And that's just not how it works. Genitals and gender are not the same. So just recognizing that and pausing and asking people. What I like to do is say, hi, I'm Krystyna. What's your name? In the medical system in particular, when we're talking about legal names and things like that, I will ask people instead, what do you like to be called? So hopefully I have your legal name. I try not to ask that first. I start with, what do you like to be called? And then go from there.
Yeah, that's actually helpful to just ask them, what do you like to be called? Because that way you can, I just feel like sometimes you get so worried about asking the right question, or, afraid of asking the wrong question, that you don't ask and assume. And sometimes that's more damage than you think. So I think it's something that gets better with practice, but it's good to talk about it. You live and you learn. You make mistakes, but as long as you're trying, in the right direction.
Yeah,
so,
trying is good, and being willing to apologize, right? So if you find out information later that's like, oh, I messed that up, just owning it, saying like, hey, I realized that I made this mistake earlier. I just wanted to let you know that I was aware of it, and I'm sorry. Which I think where not everyone learns how to do, and I think is super important in this regard in particular.
So when it comes to talking about like patients that are in the gender diversity spectrum, are there any special needs, or are there any unique pelvic health concerns that come up other than, post-operatively if they had surgeries? But do you see any particular trend of these symptoms are more common in any kind of particular patient population?
Sure, yeah. So a lot of trans men or people who are non-binary but taking testosterone and were born with a uterus often have pretty intense, so they might not call it their vagina, so there are lots of words that they could call it instead. I'll use the word canal. They might have dryness in their canal, and that can be really painful and uncomfortable. And people who are trans men or non-binary folks still might want to have penetrative intercourse. And so just letting people know that can be an issue, and then trying to solve that just like we would in any other patient is super helpful. People who are transgender women, or people who were born with penises and are non-binary and would rather not have testosterone, they might be taking estrogen, and are participating in tucking. So that's when they would put their testicles through their inguinal canal. Just letting people know that if they're having pelvic pain, that could be contributory. knowing that a lot of transgender people, when they're out in the world, don't have safe opportunities to use the restroom. And so some of the secondary problems with urinary retention, pelvic floor upregulation, these sorts of things that can be contributed to by just not having safe access to a bathroom.
Yeah. And when it comes to like treating any patient, what I wanted to go over a little bit about, what does consent mean? You know, you're obviously like explaining to the patient what pelvic floor PT is, what you're going to do. They're saying, you know, written consent, verbal consent. But I always want people to know that they can change their mind last minute. Like, you know, now they're on a table ready for a pelvic exam, like, oh, this just seems like a bad idea. You know, and then sometimes you're doing vaginal exam, sometimes you're doing rectal exam, and there's that change of consent. We're not assuming, like you said, yes, so now it's yes through your physical therapy. So can you talk a little bit about that in terms of what does consent mean? What does it look like to put those minds at ease who are still a little nervous about, I'm not sure I want to be that vulnerable in a doctor's office?
Well, and I think that's a good question for patients to ask their providers. Like, what does the consent process look like? Will you tell me before you do things? What can I expect? Because while I wish that this were standard across all medical industries, unfortunately it isn't. The way that I manage it in my own office is that I ask pretty much before I touch a patient at all, like at any time. So if I take my hands off of a patient, or if I even move my hand, especially if I'm doing an internal exam, I usually tell the patient, this is what I would like to do. Is that okay with you? And before people take their clothes off, before they even get on the table, before I'm even anywhere close enough to touch them within my 6-foot bubble of coronavirus space, right? I am asking people, you know, this is what I would like to do. This is how I think I can get the best information. And I go through things line by line. Does anything about that seem like it was not going to work for you today? No? Okay, does that seem like an exam that you would be open to today? So I ask in 2 different ways.
Yeah.
And then once we start going through the process, and we have this whole conversation, right, about like, this really is a discussion, this is a conversation, please, you know, tell me what you need. And then as we're going through the process, I would like to do this, is that okay with you? And that's something, when we were talking at the very beginning about things that I wish were reinforced in medicine, that is something that I never had, that I did not experience. Like my providers were just like, okay, I'm just going to check this thing. You're going to feel my hand. And then all of a sudden there was something inside. And even that, you know, you're going to feel my hand is what they learn as being the trauma-informed approach, or like the careful approach. I think that it should be more. I think it should be, I want to have your true consent and permission. And I want you to know that you can tell me no at any time. So I also tell people that, and I also ask them before the exam starts, do you feel confident that you would be able to tell me if you wanted me to stop? You can say it verbally, you can put your hand up. I will look for both of those things, particularly if we're in side lying and I can't see your face. I need you to just raise your hand if you're having a problem, because I just won't be able to tell.
Yeah.
So all of those things go into consent.
Yeah, I think the raising your hand is a great tip, because sometimes I feel like people struggle finding the words, because in their head they play this game of, if I say no, do I have to explain why I'm saying no? Do I have to say what happened? And they just kind of like, you know, bite their lip, and that's the last thing you want. So I feel like a nonverbal gesture just gives them permission, right? Mm-hmm. But what are some of, like, you know, some of the things that sometimes I see, I have this conversation with patients, there's a written like, have you have any history of trauma or abuse, all of that, and yet you see the body language changing, where you know that there is something that was answered no, but is a yes. And I obviously don't want to confront and make that person uncomfortable. But at the same time, you know, clinicians are looking at reactions. So is there anything to that, where you sometimes will see like tears rolling and you're like, are you okay? Yes, I'm fine. You know, and they're not even vaginal exams. Sometimes you're doing scar tissue mobilization on a cesarean scar, and this person just has some memory about it, which just brings out all these emotions. And can you speak something to that effect in terms of any anecdote or somewhere where you can kind of factor that in?
Yeah, all the time, right? So the way I internalize that, and sometimes there's a memory, like someone will say, oh, all of a sudden I just felt really like I did during delivery or something like that. But sometimes people are like, I don't even know why I'm crying. Like, what is this water coming from my eyes? Like, I feel like, but the thing is, when that's happening is not the time to be having that conversation, right? Mm-hmm. So people start crying. I stop the exam. I stop what we're doing. I get tissues, like make people feel cared for. And then normally after a couple minutes, you're like, I just don't even know why that was happening. And what I normally tell people is it is a sign from your nervous system that something is up, right? That your nervous system is in hyperdrive in this fight or flight space. And that is not the space that we want to be in during this visit. So it's not that, there's anything wrong or that I think you're weak or you need to, like, please do not apologize for your tears. It's just that's a signal to me that your nervous system isn't happy, and we need to make your nervous system happy, because that's how we get the results that you're looking for.
Yeah, that's amazing that you said that, because I remember as a younger clinician where I hadn't done pelvic health for a long time, the first thing you think is, did I do something wrong? And then you just want to know the answers, and you're like, what happened? And sometimes all you need to do is just get out of their space. And you live and you learn. But I remember those days when I would just, last thing you want is 5 more questions. I'm having a moment here, lady, like, back up. let me process this. So I think that's a good reminder to tell people that this is not the space we need to be operating in, and we need to wait for your nervous system to kind of feel more comfortable, and your body's just going to react a little bit differently. So that's sort of like body holding our emotions or our memories, if you will. Is there any truth to, like, certain belief systems holding certain emotions? Because I certainly see a lot of, like, cultural, religious, upbringing related issues that come into especially sexual health. Anything that the audience needs to know about that can kind of potentially be related to some of the problems that they have?
Yeah, absolutely. So if you grew up in a household for whatever reason that was not really sex positive, it is very likely that your nervous system interprets information about sex, even if it's consensual, even if it's within the bounds of marriage. It is very possible that your nervous system conceptualizes sex as something that's bad and dangerous, and it's going to respond accordingly. And so when I talk about your nervous system, I'm talking about some of the subconscious, unconscious things that are happening in your brain, regardless of whether or not you're controlling them. So I certainly see a lot of people who grew up with very religious backgrounds, where sex was really shameful and sinful and, like, only okay within the bounds of marriage. And even then it's like, okay, so if I didn't get married until I'm 30, I just spent 30 years of my life hearing over and over again that sex is bad, pleasure is bad, and now it's supposed to switch just because I got married. And so sometimes it works for people and sometimes it doesn't. But those are all things that can contribute to issues having an orgasm, issues getting comfortable, issues having pleasurable sex. So I think that's definitely worth mentioning.
Yeah. Thank you for saying that. And are there any things to effect of, like, preventative care? Like, for example, there are certain times in life where you don't have a problem, but you still want to go see a pelvic PT. Like, you don't wait for yourself to get a heart attack. You check your blood pressure every year in annual medical exams. And, if it's high, you intervene. You don't wait for it to actually be a problem. So are there certain times that the audience needs to be aware of, like, just, I had a baby, so I need to go get it checked out. Are there other times like that in life?
I definitely think after a baby. I think sometimes have this conversation about, okay, should I have a pelvic exam before I even get pregnant to know? I would say it's individual choice, right? So if you're not worried about it, I'm not trying to tell you that you need to be worried about it and make you fearful about anything. I think there are certainly people who never see a pelvic floor physical therapist, never have any issues, do just fine, right? But if it's on your radar and you're nervous maybe about some of the other things that we've talked about, and you're like, oh, it's not immediately a problem, but it could be a problem. I do recommend getting that checked out, because it will either confirm, yes, this is maybe an issue, and here are the things to do about it, or will give you so much relief to know, like, oh, this actually isn't a problem. Okay, this is fine.
Yeah. Either way, we've got nothing to lose, and I just feel like we need to be better at listening to our bodies. If there is a little voice in your head somewhere going, maybe you cannot logically find why, but there is subconsciously something that you've noticed which makes you worry, right? And the other thing I noticed with, like, not pelvic health, but yes, pelvic health, in a way that we tend to blame everything on pregnancies and babies. Meanwhile, some of the functions were probably a problem to begin with. So then you're training somebody postpartum, like, for example, diastasis. Did you have 0 fingers? Do we know that? Or are we just assuming that baby gave you 1.5 finger? You know what I mean? I just feel like some of those like preconception baselines, as much as they sound research type, they might be a good idea in putting people at ease when it comes to have I bounced back, if you will. So,
well, yeah, like pelvic organ prolapse, right? And connective tissue. Some people just have looser connective tissue than other people. And if you've never looked at that and don't know what your normal is, it's hard to then set goals afterwards. And then there's a little bit of a question of how relevant is it? And do I need, because there are a lot of things to worry about in life. How much can one person hold? But I do think that that's something to, think about.
Yeah. Thank you. I think that was all of my questions. And the next part is kind of my favorite part, which is called the one thing, where we go over like some, questions that I often get asked, and there really isn't like the one thing answer to them. So I'm going to go over some of the questions, and we're looking for like the one response, sometimes two, but one, mostly.
I'll try so hard.
I know. So what's the one thing you want people to know about pelvic physical therapy?
That it's a conversation.
Nice. I love it. What's the one thing you want anybody to know who's seeking care in the medical system?
That you are in charge.
Yes, very powerful. A lot of people don't know that. What's the one thing that you can tell somebody that is helpful in terms of screening themselves? What's the one thing they can do to screen themselves for pelvic health concerns?
If it's something you're worried about, get it checked.
Yes. What's the one thing
right?
that you
so
find? Yeah, because there's like such a wide question. If you're unsure, get it checked. Right? What's the one thing you find patients are afraid of when it comes to pelvic health? And I don't mean like in terms of seeking care, but like, I often get like my prolapse patients. They're just like very afraid to exercise. Like, am I going to do this and something's going to fall out? So it's the one thing that you very commonly hear patients being afraid of.
Is my sexuality normal?
Yeah. Actually, that was going to be my next question. What's the most common question you get asked about? Is this normal? So I'm guessing that's sexuality.
And orgasms. Is it normal that I can't orgasm just from penetration?
I just feel like there are different ways of asking the same question to a clinician. Am I normal? And most people are just looking for reassurance just because we lack education in that area so much, right? So what's the one common myth that you see just in and around our world when it comes to pelvic health?
I know. I mean, I think that that's it too, is like that most people orgasm from penetration, or that it's normal to have pain after pregnancy and delivery.
Yeah. And what's the one thing that you recommend everybody have? Like, if there is a product, if there is a resource book, if there is any self-help, whatever, for pelvic health concerns, or not even concerns, just awareness or education. What's the one thing that you recommend people have?
I have two. One's for pooping and it's a squatty potty, and one's for sex and it's the book Come As You Are by Emily.
Oh my God, yes, I have both of them. they're yes, you're right. And I think that's a good time to use the exception and give two answers instead of one.
Thank you. I just couldn't hold it in.
I know. That book is amazing. It's just like a myth buster from page 1 to page last, right?
Exactly.
So I think that was all of my questions based on like what people ask me. Is there anything that you feel like you get often asked? Like this is like a common question everybody asks me?
No, I'm besides the sexuality stuff, just like what is normal. I do actually, a lot of people are worried that they don't want to have sex with their partner, so that their libido has really been affected. And so just knowing that there are lots of things that go into libido, and that there are a lot of different treatment options for it.
Yeah. All right. Cool. Thank you so much, Krystyna. This was a lot of fun. I have, for my listeners here, I first knew her because of the APTA work that we do together, and she's a Northwest regional rep, and I think bugged her with 100 texts and emails with like small to big problems, and we have never really met in person, but I can't wait for one of these CSMs where we actually get to see each other face to face. So thank you for doing this. Thank you for kind of helping me on this passion project, because you know, you and me both, like you and I have the same passion of like everybody should know about pelvic health. What you choose to do with it is a different problem, but you should know that it exists.
Exactly.
Because
Exactly. We just want people to have all the information so they can make the best decisions that they can for the body that they have.
Yeah, and then that's sort of how this started, because a lot of patients told me, why didn't anybody tell me this? Why didn't anybody tell me this? And, you know, early part of my career, I was like, yeah, why didn't anybody? Why didn't the doctor say something? Why didn't the so-and-so said something? And you do this long enough and you're like, you're the part of the problem. You aren't telling anybody anything. So that's how this, you know, COVID product started.
That's so true. It's so true.
Right. So I wanted to give you a couple of minutes to kind of tell people about you, as to where to find you. What are some of the resources that they can turn to you for, your online presence? And, you know, because Krystyna has a bunch of information, and I love your Instagram posts, and I love all the interviews that you've taken. So if pelvic health is your thing, if you want more information, if you found this conversation intriguing, certainly if you're in, you know, Colorado, so a lot of things. So can you share a little bit about where to find you?
Yeah, absolutely. So Instagram is a great way to reach me. It's at Krystyna.Holland, KRYSTYNA.Holland, HOLLAND. And that's my name. And so I put out content all the time on there. You can also look at my inclusive care website, which has full-length videos on a lot of different topics. And that's www.inclusivecarellc.com. And then I also, have been on a couple of podcasts. And so if you want to just look through and see if anything kind of reaches out to you, I've done ones on movement and gym and high levels of athleticism, on trans inclusive care, in trauma informed care, any of those things. And you can just, if you put my name into Spotify, you'll get a whole list.
Okay. Thank you so much.
Thank you so much for having me. This was so fun.
Yes. Have a wonderful weekend. Thank you for listening in. I hope you enjoyed this episode, and I really hope you got something out of it. I appreciate your time, and I enjoy hearing back from you guys. So if there are any questions, comments, or concerns, you know where to find me. If there's a topic that you've been wanting to hear about, reach out to me and I'll see what I can do. Once again, thank you for being here. Stay safe, and don't forget to come back. Peace out.